We're good? Yeah. Okay, we're gonna get started. Thank you everyone for coming. I'm very excited to have Dr. Thomas here. She's a local OBGYN who's going to impart her wisdom on us and answer some juicy questions after too.
Yeah, happy
Okay,
to.
so,
Thank
yeah,
you.
thank you.
Hello, everyone. Thank you so much for coming tonight. First of all, I want to thank you for postponing this week. Influenza is no joke and totally kicked my ass. So I'm doing my best with my voice. I'm definitely got a post-viral cough that I'm going to cough through this, and I got my tea, and we're just going to do our best because this is literally one of my favorite things to talk about. I talk about it all day long with my patients. I did today. I'm doing it to date. Would love to chat with you guys about perimenopause and menopause. So I've just thrown some slides together just to kind of help keep me on track because I will talk for hours and we don't have hours. So try to keep us on track here. I'm going to just kind of broadly start talking about what is perimenopause and menopause, from a biology standpoint, what the hell is happening with our bodies. The only study I'm going to kind of dive a little bit down into is the Women's Health Initiative, the WHI, because we are 20 years later, still debunking and getting rid of the damage of the WHI. I'm going to talk about some medical options for menopausal hormone therapy, take a brief detour into the fresh hell that is perimenopause as opposed to postmenopausal symptoms. I'm going to talk a bit about our long-term health goals. We're going to talk about vaginas because the genitourinary symptoms are important. And just at the end, I have a quick update on some cancer screening changes that have just changed recently, which is important for all of us to know. The information I'm going to be sharing tonight comes mainly from the Canadian Menopause Society, from our Society of OBGYNs of Canada, and from NAMS, which is the North American Menopause Society. So that's where I've gotten pretty much everything here. I am going to speak out of my own opinion sometimes. I'm going to talk about some off-label use of medications as well. But that's where the majority of my stuff is coming from today. Okay, so what is menopause? When you look at the actual textbook definition, it's when you've gone that 12 calendar months without a period. And when you finally hit 12 months with zero bleeding, you draw a line in the sand and say, congratulations, this is menopause. All the crap that happened in that 5 to 10 years leading up to that, we call perimenopause, and your life afterwards is postmenopause. Now, culturally, we don't actually talk about it that way. We talk about menopause. Actually, we like the term menopause transition because it really is a transition in these kind of 5 to 10, 15 plus years of what our bodies are going through. And I think that makes it easier to think about. When we come to kind of average duration of when women are experiencing hot flashes and night sweats and that sort of stuff, on average, it's about 7 years. About 50% of women are going to have that 7 years, but that's quite a ballpark because there's a lucky few women who breeze through or they have symptoms for a few months. There's a lucky 15% who have symptoms for over 15 years. So it really is a broad range. And we're learning more about the timing of when these symptoms happen related to when your periods actually stop. So in women who start having really bad, hot flashes, night sweats, a whole bunch of other symptoms years before their period finally ends, those symptoms tend to be a lot more severe and last longer, as opposed to the women who don't really have any symptoms until their period's done, and then maybe like 6 months, a year later, then they have some symptoms. Those tend to be more mild and not last as long. So we know there is a bit of a timing thing too, as far as like when the symptoms are going to start, how long they're going to last, how severe they are. But I tell my patients I don't have a menopause crystal ball to know for you specifically when this is all going to end. And menopause in general is kind of a new thing in the history of the world because, we used to have 10 babies and then die in childbirth and we'd never really get to 50. So it's really just kind of been in the last 100 years or so that we're healthy enough to actually live several decades past that last period. So that's part of why this is kind of a relatively new thing in the history of humanity, that we have so many decades of life after we've gone through this change in our reproduction. So what the hell is happening to our bodies? So it's helpful to think about what is happening in our ovaries. So we as women are born with as many eggs as we're ever going to have. And then by the time you hit puberty, most of them are gone. And then we're left with our basket of eggs that you're going to have for the remainder of your reproductive life. as opposed to men who makes new sperm every few days. We are left with whatever we're going to have. And by the time we hit our 40s, the quality and quantity of those eggs left are not what they were when we were 18. So the patterns of hormones that we're getting that are going from the brain down to the ovaries down to the uterus, that cycle starts getting screwed up, which is why this is a transition. Like, we don't go perfect, wonderful cycles, nothing. There's that kind of 5 to 10 year period of this menopause transition where we're not necessarily ovulating regularly. And if we are ovulating regularly, those signals are getting really effed up. So I liked this chart that it kind of talks about what is that perimenopause transition looking like? Because the early part looks different than the later part. So the early part for a lot of women, you're still ovulating. You often will still get periods once a month, but the actual quality of ovulations suck. So what happens when you ovulate is you create that progesterone. So you're still making estrogen, but that progesterone is not quite there the way it used to be. And progesterone's good for our brains. It's good for our sleep. It's good for our moods. So often for a lot of women, they might still be having their monthly periods, but their sleep is getting really disturbed. They start getting some night sweats. They start getting some irritability where you just want to rip everybody's head off in your household. And that can be some of the earlier changes before we start getting a bit later, and then you start skipping periods. And then you're not having them quite so often, and things start spacing out, and then your estrogen levels are starting to drop. So then the daytime hot flashes and the joint pain and the brain fog and that sort of stuff starts kicking in. So where you are kind of in this weird perimenopause transition, your symptoms can be very different. And I'll have people be like, well, I feel good for a few weeks, and then I feel like crap for a few weeks, and then I feel good for a few weeks. And I'm like, yeah, because you were probably ovulating, making estrogen, and then your ovaries took a hiatus for a while. They were on sabbatical, and then they came back. So your hormone levels are really kind of going like this. So it can feel very strange and out of control. One helpful metaphor is this is kind of the inverse of puberty. Nobody said, when did puberty start and end for you? What were the dates, right? At some point you were just like, oh, I guess this is me now as a teenager. And now I'm in my 20s, and now I'm an adult. And that stuff was weird back then. It's kind of the inverse, except we're women in our 40s and 50s, and we got shit to do. And we got kids to take care of and aging parents, and we're supposed to be at the top of our careers right now. And what the hell is happening to our bodies? So it's very different than when you were 13. But reproductively, it's kind of the inverse of what was happening back then. When you finally hit that last period, that's when you've completely run out of eggs. And your ovaries are done, they're retired, and they're no longer creating the estrogen, the progesterone, the testosterone that you used to make. And that's then your kind of post-menopause life, where you've now settled into this transition of you're not going to be making estrogen any further. So from a biology standpoint, that's kind of what we're talking about here. And we used to only talk about hot flashes and night sweats. When I first started, the questions I asked is, do you have hot flashes and night sweats? And we now know there's a heck of a lot more symptoms than just the hot flashes and night sweats. Sleep disturbance is huge. And when we don't sleep, our brains don't work. And when our brains don't work, we get the brain fog and the memory stuff, and we're real irritable. The mood changes start. Perimenopause is actually the highest risk time in your life of anxiety and depression. We focus on postpartum. It's actually perimenopause. And that's really under-recognized, but a lot of women recognize that in themselves, that for the first time you're feeling super anxious and out of control of your moods. As I talked about the cognitive stuff with the brain fog, joint pain is a big thing with lack of estrogen, which people often don't put together with menopause. There's the body composition changes, because my office is filled with women who don't like this. And it's real. It's a real thing. There is a fundamental change in the way your body chooses to store and distribute fat during this transition. They're not crazy. It's a real thing. I also want to focus on what we now call the genitourinary syndrome of menopause. So there's massive changes in our vaginas and our bladders with the lack of estrogen. So the vaginal dryness, the pain with intercourse. We're not good at talking about these stuff, but over 50% of women after menopause are going to experience this. And some of the more subtle bladder changes, because there are bladder receptors all around the base of the bladder, or estrogen receptors all around the base of the bladder. So that mild urgency or frequency, that mild stress incontinence of the coughing, laughing, sneezing, there's a menopause component to that and a lack of estrogen component as well. So we need to not ignore this, because this is very important too. So let's talk about the WHI. Let's put this in context. We're going to go back to the 90s. We were all around in the 90s. What happened in the 90s is that we got really excited about how good estrogen was for our hearts. So in the 90s, a woman who was 75 had her heart attack, and her cardiologist wrote her a prescription for hormone replacement therapy because estrogen is good for your heart. And the reason we thought that is that our risk of cardiac disease starts accelerating, matching that of men when we hit postmenopause. So estrogen must be good, right? So what the Women's Health Initiative was, it was a massive study done in the States trying to prove the point that estrogen was good for women's hearts. So they took a whole bunch of women in their 50s up until their 80s and put them on estrogen and progesterone if they had a uterus, or estrogen alone if they have had a hysterectomy. And the study was stopped early because of the increased risk of heart disease, stroke, breast cancer, and the whole world lost their flipping minds. These were all the headlines, that HRT is dangerous. And everybody stopped their HRT cold turkey. The damage that this study did cannot be understated. There is a whole generation of women who grew up with this messaging that hormones were really bad and hormones were going to give you cancer. And there was a whole generation of physicians who grew up in this time frame, a whole bunch of physicians who were really burned by this and haven't really recovered. And so we went from hormones for everyone, WHA came out, hormones for nobody, hormones are the devil, and here we are 20 years later, and the pendulum is very happily swung back, because 20 years later we have such better studies, huge, big, excellent studies that are asking the right question. Because when you started actually looking at the WHI, it was the women who hadn't seen estrogen for 20, 30 years who are having the increased risk of heart disease, stroke, the women in their 70s and 80s who all of a sudden got put on HRT. When you looked at the women in their 50s who were just going through that menopause transition, they had barely any increase, maybe like 1 to 2 extra cases per 10,000 women, barely increase. And actually they did great. Their hot flashes and night sweats were awesome. If anything, it was actually good for their hearts, but all of that got lost in the messaging of the big study. So we did actually learn something from the WHI. We learned that we shouldn't give a 75-year-old who hasn't seen estrogen in 20 years, we shouldn't give her estrogen, because that's not great for her heart. Because what we've learned from the kind of heart cardioprotective standpoint is that when you get women early, when you get women like around the age in their 50s and they're just going through this transition, before they've created all the plaques in their coronary arteries and the hardened vessels and all that stuff, before they've gotten their hypertension and all the rest of the stuff, then estrogen is good for our hearts. So the timing is important. And we know that now later. So when I first started practice 12 years ago, I would have women with horrendous symptoms and I would go through this and I'd spend time begging them to please consider hormone therapy. And it was like pulling teeth. Today I have women beating down my door wanting hormone therapy. So it's really cool to be at this stage with better information, better messaging out about what we do have, and women being able to consider taking advantage of this, again, on an individualized basis, based on their own health history, when their last periods were, their age and all that sort of stuff. But it's a really cool place to be now. So this is exciting. I like to just mention this because breast cancer is this kind of specter that hovers over anybody who has breasts. 1 in 7 women are going to get breast cancer. It is like one of the most common cancers that we're going to face in our life. But most women are much older. They're these tiny little tumors. They have lumpectomies. That's not the young women who are dying that we have in our heads, right? That's actually the reality of it. So when you look at what's your highest risk up there at the top, it's whether you're a woman who has 2 breasts and you're over the age of 65. When you look at the things that just slightly increase your risk of breast cancer, like just over that relative risk of 1, it's if you don't exercise regularly, if you smoke, if you're overweight, if you drink 2 or more drinks of alcohol a day, and if you use menopausal hormone therapy for about 5-ish years. They're all equivalent. So these risks that so many people just take on a daily basis without thinking about it is actually the same risk of using hormone therapy for a few years. And then that second to bottom line is that after you stop hormone therapy, your risk normalizes back down to the baseline. So this isn't an elevated risk that continues for you. So it's nice to just kind of put risks in context, because I think there's a big pink specter with breast cancer for women. So 20 odd years later, here's the position statement from all of our big professional societies, NAMS, SOGC, our Canadian Menopause Society, and a whole bunch more internationally, that menopausal hormone therapy is the most effective treatment for bothersome hot flashes or night sweats with or without other treatments in menopausal women. It is our gold standard. It is the thing that works the best. But here's the timing issue to maximizing this safety, that ideally it needs to be started in women under the age of 60 and or less than 10 years from their last period, whichever's longer, basically. So that's what we're keeping in mind when we're looking at starting someone, is paying attention to the safety with the timing of it. If somebody has a uterus, we need to balance estrogen with something. And the reason for that is if you're postmenopausal, your ovaries aren't doing anything, you give someone estrogen, it's fertilizer that is going to make your lining of the uterus grow. So we can give women precancer and cancer by giving them unopposed estrogen when they have a uterus. So you need something to balance that out. So traditionally, that's always been progesterone. We have some other options that I'm going to bring up too. We now also know good things that progesterone by itself does, so that's cool too. And women who have had a hysterectomy, they do have the option of only using estrogen. So it is also a question of, do you still have your lady bag there? And I literally have a cookbook of different options for women. And there are things that I like better than others and nicer combinations. But to break them down kind of really simply, estrogen can be done in a pill form, in a patch, in a gel. So there's transdermal options and oral options. Progesterone's really only done by itself as a pill, because progesterone doesn't absorb well through our skin. Very different from estrogen that does absorb very well through our skin. I didn't put it here, but IUDs, the progesterone-containing IUDs, another really nice option to use as part of menopausal hormone therapy. There are some combination products that have estrogen and progesterone in them, which can be pills or patches. I'm going to spend a little bit of time on these 3 on the bottom because they're super cool and some of my faves. Duaviv is really interesting because it's 1 pill a day that has estrogen and what we call a SERM, a selective estrogen receptor modulator. It's a medicine that is anti-estrogen at the level of the uterus. So instead of having to pair it with progesterone, we can give you the estrogen plus the SERM. Where I really like this is that there's many women who, when we first start them on some hormone therapy, they have a little bit of spotting when it first starts. Your uterus is just kind of getting used to it. Usually that goes away after the first couple months. But if that persists and starts getting annoying, you just want something that's more suppressive at the level of the uterus. So that's where Duaviv really shines. Tibella is also super cool. Tibella came over from Europe about 5 or 6 years ago. It's really interesting because it's a hormone precursor that your body breaks down into estrogen, progesterone, and a little bit of testosterone. It's the only one that actually has a testosterone component built into it. Again, 1 pill a day, 1 dose, provides kind of everything you need. And it's also really good for women who have annoying spotting because that testosterone is extra suppressive as well. Veoza is beyond cool. So this just hit the pharmacies literally a few weeks ago. It is the very first time in the history of modern medicine and menopause that we have a non-hormonal medication that's specifically for hot flashes and night sweats. So the way the hot flashes and night sweats work is we have this like thermoregulatory area in our brain. It's like a thermostat of our brain that has two main receptors in it. It has estrogen and this neurotransmitter called neurokinin. All of the stuff I've just talked about worked on the estrogen part of your thermostat. This new medication, Veoza, works on that neurokinin receptor part of it. So it's still working on the thermostat part of your brain, but without needing estrogen. So there's very few actual like full contraindications for women not being able to take hormone therapy. Breast cancer being one of them, and our breast cancer survivors, people who have had heart attacks, all of a sudden I have an option for them, which is so cool. So this literally just hit the shelves. I've written 1 or 2 prescriptions. I'm really excited about it in the long term. It's been in the States for about 1.5 years so far, but it's the first time we've had something completely different than estrogen, progesterone. So that's super cool. Within my medical options, there's a few things I like to think about. We know a lot about transdermal estrogen being especially awesome. So when we put estrogen on our skin, whether that's through a gel, whether that's through our patch, it absorbs really well, even better than when we swallow it orally. And it actually has an even better safety profile when it comes to heart and stroke and all of that stuff than by taking things orally. So I do love pairing transdermal estrogen with my other favorite, with is micronized progesterone. So micronized progesterone, the trade name for that is Prometrium. We've always loved it as part of hormone therapy because it has a nice sedating side effect. So it's real nice for sleep. So when you take it within that like hour before bed, beautiful sleep. But even by itself, it has a bit of a mood stabilizing effect. So it's really nice for that irritability. And it even can help with some hot flashes and night sweats on its own. So I do a lot of combinations of like transdermals plus micronized progesterone because they work nicely together. I also just want to make a mention of the term bioidentical. What the hell does that mean? So in the giant void that the WHI created, the industry of compounded bioidentical hormone therapy rushed in to fill the void of everybody mistrusting modern medicine and their doctors. So when you actually think about like what does the term bioidentical mean? It really means that whatever you're taking from a chemical structure looks like what your body makes. So I prescribe all the stuff I've talked about are Health Canada approved products because they are regulated, they are well studied, I know what's in them. And many of the things I've just talked about, all those transdermal estrogens, they're all bioidentical. They're all 17 beta estradiol, which is what your body's making. So a lot of the things that I prescribe that are Health Canada approved are bioidentical, if that's an important term for someone. Where my concern as a gynecologist comes in is the compounding part of things, because compounding isn't regulated as an industry. So when somebody is compounding you an estrogen cream, dear God, a progesterone cream that's not absorbed well in your skin, we don't know what's in that, and it can be different with every batch. So I have unfortunately seen women who have cancer. They have endometrial cancer because of bioidentical compounded stuff that they got at a compounding pharmacy. So that's where my bias comes in, that I get real nervous. As you've just told, you can tell I'm really excited about menopausal hormone therapy. I love giving men menopausal hormone therapy. But I do stick with Health Canada approved products because that's my concerns. And I'm speaking to the choir here. When I'm sitting here talking to somebody about menopause and perimenopause, what else do we need to be talking about? We need to be talking about what's going to keep us healthy and functional so we can live more productive, functional lives. We don't want to just live longer. We want to live better. We want to improve our health span. So the stuff that you guys do in this building is amazing. Because when I have patients come and they want to talk about this, and they're worried either that hormone therapy is going to make this worse or make it, or wanting it because they think it's going to make it better, what's actually going to help is lifting heavy shit, is what you guys do here. It is weight-bearing exercise. We need to lift heavy things so that we are building our muscle mass. And that's super important to protect our bones because our bone health starts dropping off after menopause. It's really important because muscle is a lot more metabolically active as far as burning calories more efficiently. And we need to be strong. We need to lift things. We need to play with our grandkids. We need to be able to do stuff and travel and not fall and break our hips as we get older. So when women are like, yeah, but I walk all day at work, that's awesome. Cardiovascular stuff's still awesome. I need you to lift heavy shit. I need you to lift some heavy things and start building our muscle mass, which is so important. And when you're building muscle mass, you need protein. Ladies, we need protein. Again, talking to the choir here. We need protein to build our muscle mass. We need fiber to keep our bowels moving and to reduce our risk of colon cancer. It's also really good for our hearts. There's good evidence about more of a Mediterranean style diet where we're eating lots of fresh fruits and vegetables. We need to look at what else we can change in our life. We need to try to cut down on smoking. We need to take a good hard look at our alcohol intake. These are all things that are important as far as how do we stay healthy and live longer. I have another little beware up there of supplements. So in the excitement everyone's having about now finally talking about menopause, there's again been a lot of people swooping in who can make a lot of money. So I'm sure any of you going on your social media, there's lots of ads flashing up about take this supplement and you'll lose your menopausal belly fat and blah, blah, blah. Again, supplements aren't regulated. We don't know what's in them. They can be very dangerous. And I'm inherently wary of people who are making a lot of money off menopausal women. So that's where I have my beware of supplements. What we do need for supplements is we need calcium, vitamin D. This is good for our bones. We know that our bone health starts to suffer when estrogen goes down. So actually the other indication that NAMS, the North American Menopause Society, has for menopausal hormone therapy is protection of bone health. We've talked a lot about our hearts. We know when estrogen is started in the right time, it is cardioprotective. When it's started in the right time, it's actually good for our glucose and our insulin metabolism as well. So it's great for our ladies with controlled diabetes to help them get better insulin control. One of the awesome Canadian guru gynecologist badasses, her name is Dr. Natalie Gamache. She teaches us all so much. One of her main things is when she sees women who are really suffering from menopausal symptoms is also taking a step back and saying, what else could this be? So she checks their iron stores, she checks their thyroid, she checks their vitamin D, and she picks up a ton of deficiencies. So I've added this as part of my practice too for a lot of women, especially if I'm not getting where I want to, let's check your iron stores, let's check your vitamin D. These are things we can supplement and we can do better with. So I've talked a lot about the when our periods have ended life, because I think that's kind of nice it's a bit cleaner to think about as far as where hormone therapy fits. But we need to talk about the fresh hell that is perimenopause. Because I find this challenging for a lot of women and to figure out how to manage them, because you're fighting with two competing things. You're fighting with a uterus that's being stupid and bleeding all over the friggin' place, but still having these menopausal symptoms. And I want to make sure that whatever I'm doing to help with the menopausal symptoms, I'm not making the bleeding worse. So it's trying to hold these two things and really individualize things for where women are at in any specific time. This is where I use a lot of the Mirena IUD system, so a progesterone-containing IUD, because when it's sitting there in the uterus, it's thinning out the lining of the uterus. It's also my balance for estrogen when we get to menopausal hormone therapy, so there's a lot of good things about both of them. For some women, this might be a birth control pill, which is estrogen and progesterone, but just in a higher dose than we would use in just pure menopause, because I need that for the bleeding control. This might mean some minimally invasive surgical things, like maybe someone needs an endometrial ablation. Worst case scenario, maybe somebody does need a hysterectomy if we've kind of exhausted our options. But we also need to deal with the bleeding shit that women are dealing with. And we just talked about at the beginning, like, what are some of those early changes that women are having? That maybe their periods are still coming once a month and they're not that bad right now, but I'm not sleeping. and I'm ripping everybody's heads off. And this is where the glory of micronized progesterone comes in, that they're kind of almost in a relative progesterone imbalance, that they still have estrogen around, but it's those crappy ovulations, the progesterone that's not there. So when I give them progesterone alone, they start sleeping better, their mood's more stable. It's not going to do anything bad to their periods because it's progesterone only. So this has been a kind of a recent change in my practice in the last year or two, that I'm doing a lot of prometrium in women in perimenopause and having some great success with it. So this is really cool. Okay, I want to talk about our vaginas because they're important. So, as I said, over 50% of women are going to be experiencing vaginal dryness, and they're going to be experiencing pain with intercourse, and we're not good at talking about this, and we're embarrassed, and we don't say anything, and it gets real bad by the time people come and see me. There are some really lucky women who do well with just a lubricant with intercourse, or maybe like a non-hormonal vaginal moisturizer that you can use. Even in women who are feeling okay, I always say just plan for a lubricant with menopause, because we don't want friction. We don't want that sandpaper friction happening. We've got tons of good vaginal estrogen therapies. And vaginal estrogen is very different than full body estrogen because it's really only going locally to the vagina. It's just being absorbed locally to that vaginal mucosa, the skin of the vagina. And it's going to increase that blood supply moisture elasticity to the tissue. And that can be done in tablets, that can be done in creams. There's a ring that's impossible to get. There's 2 new kids on the block, which are really cool. There's a vaginal DHEA, which breaks down into estrogen and testosterone, because there are also testosterone receptors in the vagina. So that's cool. There is an oral medication that is not an estrogen. It's, again, that SERM type medication, but it's turning on the estrogen receptors in the vagina. So there's an option. We have vaginal laser therapy. I own a laser. But I also want to focus on that we can do all these things to help the vagina, but a lot of women end up getting this secondary response called vaginismus. So what that is that if you're having intercourse and it feels like sandpaper, and then you bleed afterwards, and then it burns every time you pee for the next 3 days, and you're like, why in God's name did I do that? Your muscles, your pelvic floor muscles, next time someone goes to touch you, are going to do this. They're going to get real tight because they're trying to protect you. Your body's trying to protect you. So we can do everything we can to fix the surface level skin, but if your muscles are doing this underneath, we also need to address that. And that's where our pelvic floor physiotherapy friends shine. This is where we talk about exercises to desensitize these muscles, to teach the muscles that we don't have to try to protect ourselves. But that's why I love to see women early before they get to the vaginismus stage, because then we got a whole other level of stuff to try to help with. So this is an exciting time that everybody's talking about menopause, which is amazing, and women are empowered, and I want you to talk to people and talk to your friends and talk to your doctors. But there's also a lot of stuff out there. So where's good quality information we can trust? So the Canadian Menopause Society has some great stuff, both for women and for healthcare providers. My local professional society of OBGYNs of Canada, they have a website called MenopauseNU, the letter U.ca. The North American Menopause Society is great with menopause.org. So these are big, trusted organizations who've done a ton of research, have great guidelines, and have award-winning quality information that is on the web for you guys. So this is great stuff. There's a lot of voices on social media. It takes a bit of teasing through about who's good quality. My personal recommendations is I really like Dr. Jen Gunter. She is a Canadian gynecologist who's in California, is moving back to Canada soon. She's very, very evidence-based. She wrote the Menopause Manifesto. She's got a great Substack called The Vagenda. She has some very strong opinions, but she really is very evidence-based and likes to break things down and say, this is coming up on the internet, let's actually talk about the evidence behind it. Dr. Marie-Claire Haver is a big name when it comes to menopause. I really appreciate that she has pushed the menopause message so far and is empowering women and giving women, for the most part, really good information. Again, my caveat is she also sells supplements. So I just have that when people are making money off menopause as well. So that is my only hesitation with her. But definitely these big societies have excellent quality information. I will finally stop talking soon and take questions, I promise. Just a quick couple things for you guys to know about, tell your girlfriends about. In the fall, they changed the start date for mammograms from 50 down to 40. So any women from age 40 on, if you choose, can now get a mammogram through the Ontario Breast Screening Program, which is awesome. My personal, very excited hat is I'm our regional lead for cervical cancer screening. And we just at the beginning of March have changed how we screen for cervical cancer. So right now it is still going to feel the same for you guys with a speculum exam, the little broom. But instead of looking at cells now, we are testing everyone for high-risk HPV, which is the virus that's causing precancer and cancer on the cervix. And if you don't have HPV, if you don't have the thing that causes the thing, you're not going to get the thing, which is great. So we're actually having a much better test for people. So now when you go for your next PAP, and it's now an HPV test, if you are high-risk HPV negative, we can now go to 5-year screening, which is awesome. So that is new as of 6 weeks ago. It's going great so far. We're really excited. We are working on self-sampling. Many other places in the world already have it. The pilot projects are coming through in Ontario, where I believe in the next kind of 2 to 3 years, we're going to be getting to a point where you can choose to have a kit mailed to you with a vaginal swab that you do yourself at home and mail the kit back. And that vaginal swab will be able to test for HPV. So that is coming. It is not here yet, but that's what's on the horizon for cervical cancer screening stuff. Cool. I've talked a lot. I hope this was helpful. I am very happy to answer questions. I know there were a few that were put forward in advance. I'm happy to do whatever. I could talk for another couple hours. I know I've only kind of skimmed certain things, so I'm happy to go into more detail about whatever people would like.
Can I ask an easy question?
Please.
On your last slide?
Yes.
Do you mind putting it back up?
Yes.
So, my daughter, strangely, received a note from her family doctor about the HPV testing. She's 25.
Yep. I was about to say that now starts at 25.
Yeah.
Yes.
She's 25. So
Yes.
maybe she come in. So,
yeah.
But for us, so if you're normally supposed to be having a PAP this year, you won't have a PAP, you'll have this instead.
Correct.
All doctors' offices, nothing to do with gynecology.
All of Ontario.
Every single person.
Every single person doing cervical cancer screening. No. It is the standard now. This is all that they're doing.
And once you have that, what you're saying is if you don't have the thing that causes the thing,
yes,
then you then come in every 5 years.
Every 5 years, yes.
And that will be the same for a 25-year-old as well.
Correct. Correct. Now, if you just had a PAP test last year, you're waiting 2 years for your next one. So you're in the old system where you're in the 3-year interval, but then the next time you're due for it, then it's the HPV test, and now we're into the new system. Yes. Sarah.
I missed that, but is the HPV testing is a PAP?
So right now, for women, it feels the exact same as it always has. It's a speculum exam. It's the little broom on the cervix. But instead of that primarily looking at cells, which is what it used to do, it's testing for HPV first and only looking at the cells if that high-risk HPV is positive. Just cool. Australia's been doing this for like 8 years. We're really far behind, but we got there.
So I'll maybe ask a couple of the questions that got submitted.
Please.
And then we can maybe more dialogue.
Yes.
If someone has fibroids and is on HRT, so that's estrogel and oral progesterone,
yep.
Can the fibroids become problematic, or what are the options to manage this?
Yeah, so what fibroids are is there's knots of smooth muscle that live in the lining of the uterus. They're incredibly common. Over 50% of women, by the time you hit 50, are going to have at least one fibroid. Usually what happens is that after menopause, they shrink because they are fed by your own natural estrogens and progesterones. So they usually shrink and they usually calcify afterwards. Being on menopausal hormone therapy shouldn't make fibroids worse. Because what we're giving women is such a baby dose compared to what you used to have before that it shouldn't make the fibroids grow or be more problematic. I guess I'd want more questions about what do you mean by problematic? Is it, are Are we having bleeding? Because that's a totally different issue. Some women who have really big fibroids, like it feels like they're pregnant, really big fibroids, the amount that they can shrink after menopause is sometimes not enough to get rid of those bulk symptoms. So then often we're looking at surgery to try to remove them. If maybe your periods are done, but you have a uterus that's that big and filling up your entire bowels, which are soon, then sometimes surgery is the option in that case. But overall, fibroids should shrink after menopause.
What causes tinnitus in perimenopause?
I have no idea. No idea.
Is that a thing though?
I've heard it. I tried to look it up. I couldn't find any good quality resources that talk about it. Again, with that whole like pendulum swinging, the list of things that could be menopause has all of a sudden become every symptom known to mankind, and that's probably not the case. So I've heard it. I have zero helpful things to say about it. Sorry, not helpful.
Okay, I'm going to be 60 this year and I've never been on HRT. I exercise often, try to sleep well, don't smoke or drink, and follow a very healthy eating plan. I feel I experience brain fog often. Can I go on HRT? If no, what can I do to help?
Yeah. So I liked this one because this comes up often that, again, left over from the WHI, women have been burned. And then all of a sudden now it's like, well, geez, my last period was 10 or 15 years ago. And now I want to get on this hormone bandwagon. I feel like I've been left behind. Or I still have symptoms. What do I do? So with that question, I'd really want to do a deep dive into that specific person's health history about, when was their last period, what other menopausal symptoms they had, maybe didn't have at the time. Is there anything else in their, have they had breast cancer? Have they had a heart attack? Do they have any other contraindications? Because I think in a well-informed person who knows about the risks and benefits, that if they're having brain fog that we think is estrogen related, and they're able to weigh those pros and cons and say, yes, maybe I am 60, but my last period was only 8 years ago and whatever, that I'd be very happy to try some menopausal hormone therapy in that situation and see if it would make a difference. But I think it really has to be individualized for someone, especially when we're kind of at those extremes of the like less than 60, less than 10 years. But women are able to make their own choices. Like there's very few situations where I'm like, you don't get estrogen. Because I think women are able to make their own choices as long as we have a good balanced conversation about what the risks are and what the effect of their quality of life is. And I think this goes into, I'm just going to jump into one of the other questions that had come up of like, how long can I stay on this? That's a great question. I used to tell women, that we've got good safety data for 10 to 15 years. I don't even say that anymore because the data, again, has swung that for women who are able to sit and have the pros and cons conversation, that they should be able to stay on it as long as their health hasn't dramatically changed. And they're able to say, yep, here's the very small risk. Here's how I feel on it. And I mean, even before this better data, I'd have women in their 80s and saying, sweetheart, you can take my HRT out of my cold dead hands. And I'm like, cool. I'm not doing that. You live your life. You do you, girl. Like, who am I to say no at this point? And I have a lot of patients who their family doctor did say that at some point, and they were taken off their hormones, and now they feel terrible, and now we're trying to backtrack. Now, having this Veoza is really cool for women where their symptoms primarily are hot flashes and night sweats, because hey, no issue with the estrogen there, let's do it. So I now have that tool that I didn't have before. So it will be really exciting to see where that takes us to have this kind of non-hormonal option. But yeah, I think a lot of these decisions have to be individualized. I'm really trying to, part of what I'm doing here is, at the same time Sarah asked me to do this, I had talked with our Ontario Health team about saying I'd love to do a talk for healthcare providers, and I'd love to do a talk for women in the public on menopause and perimenopause, because I'd really love to empower our family doctors to feel more comfortable about prescribing menopausal hormone therapy. Because I unfortunately am popular. Like my wait lists are easily 7 months. So by the time women have come to see me, or come to see their family doctor saying, I want to talk about hormone therapy. And they say, great, you should go see a gynecologist. It's another 7 months that they're suffering, where I'd love for them to be able to feel more comfortable about starting things. Because frankly, the medical school curriculum sucks. Like women's health is not given the appropriate focus that it should, especially menopausal health. So they're like, well, I've had like a 2-hour lecture in my entire medical school about this. So of course I don't feel comfortable. So I have done these presentations. I'm arranging to do them with our local GPs and nurse practitioners. I'd like to do more like this. You guys are kind of my guinea pigs for tonight, for doing more of kind of a public facing one. So I'm really trying to do my part as a gynecologist to get this word out, because this should not just be the realm of the gynecologists who eat, sleep, and breathe this stuff. Like, it should be more accessible through our primary care providers. We have some great nurse practitioners in this town. They're nicely on the bandwagon. I usually just help them tweak stuff, but some of our GPs need some help. Was that all the questions there? Yes.
We all been to our GP.
Yeah. Can I please see Dr. Thomas? Sure.
Can we go back to the non-estrogen thing for, what's it called?
Veoza.
Are there any side effects or anything with that?
So yeah, so the only thing that has come up is that for some women, they can have a bit of an effect on their liver. So the only real contraindication is women who have true liver disease, like hepatitis and liver failure. So the only kind of monitoring that we are having to be doing is, for the first couple months, we're doing monthly blood work, looking at their liver levels and just making sure those liver enzymes are fine. But that's really the main thing.
So why would we not do that versus hormone therapy? Like,
For everybody? Yeah. Well, so I think Veoza is brand new and it's expensive. And we know that there is so much benefit of estrogen and progesterone in women who have the right timing and, no other health concerns. So I think estrogen and progesterone is still awesome for the vast majority of the population. Where I think Veoza is going to shine is in these women where they don't have access to the estrogen and progesterone that everybody else can, because they have these few, like, really bad health contraindications. Again, my breast cancer survivors are my top of mind here, because, oh my God, breast cancer treatment can give you some nasty side effects from a sexual health standpoint. And I love our oncologists. They do such an amazing job, but they have their cancer blinders on, that it's all about decreasing risk of recurrence. And I have women who are just debilitated by their sexual side effects and their hot flashes and night sweats. And so just having more options is really cool. Yes.
So when you're talking about how the goal is for you to be able to talk to the GPs and give them the information to be able to effectively prescribe HRT.
Yeah.
What about for individuals in terms of friends or family members who don't have the best GP? What's the best way to advocate for themselves to get the help they need?
Yeah. So I think step one is going to the resources that we just talked about, because I think educating themselves is number one when you can come with that, like, information behind you. But if you're having that encounter with someone who is just not receptive to this and really shutting you down, is finding other ways to access a referral to a gynecologist. And if that's going to a walk-in clinic and asking for that referral, then so be it. I think people need to advocate for themselves, and if they're getting a bit of a roadblock from primary care, then we need to look at other avenues. Yeah.
Will we be getting copies of the slides? Can we
I
get
can.
copies?
I'm happy to. Yeah. Our GPs are great. Our GPs are amazing.
This is being recorded, by the way.
I was about to say,
I have video.
I love our local GPs and nurse practitioners. They're amazing. No, I think it's the WHI. I think it's the WHI. 20 years later, we're still recovering from. I think it's the lack of focus on women's health in medical education, in residency and in family practice residency. I think it's a systemic problem. I truly do. So just trying to get more education out there as part of a way of tackling that systemic issue. So yeah, like I get it. Like if you lived through the WHI and you had hundreds of women banging on your door saying like you're giving me things that are going to cause cancer, like that's rough. To be like, oh no, they say it's fine now. Like it's different. Like I came of age. You know, I started my, see if I can do math. I started medical school in 2005, so I started like 3 years after the WHI came out, and even then, the information was starting to flow that of everything that was wrong. WHI is also a great way of teaching statistics and how to manipulate numbers to tell whatever story you would like it to tell. Can go on a tangent about that. And then by the time I was in residency, we had all these better studies out. So I very much came of age in the menopausal hormone therapy is great. And here's all the reasons why. So I wasn't kind of infected in that stigma of the WHI. So it's also kind of the culture that you grew up in and you learned in. But you know, our menopausal women now, they were 50, they were 30 when this all came out. So like we remember these things. Yeah.
If I'm a woman who,
Yes. We're doing the hypothetical. I love that you're here. I'm so glad you're here.
This is all novel to me, and I haven't done any of this, like the lifestyle changes, the exercise, the eating,
Yeah.
the hormones,
Yeah.
all that sort of stuff. And I have 10 billion things going on in
Yeah.
my life, and I'm super overwhelmed to try to tackle all of it at once.
Totally.
What's your order of operations? Do you have a recommendation like this is where you start, this is where you progress?
Totally.
Yeah.
So Natalie Gamache that I mentioned really says it beautifully. Like you have a woman in front of you who is losing her mind. She hasn't slept in a year. She's completely overwhelmed by life. She's debilitated by her hot flashes and night sweats. And for her to walk in your office and you to be like, you just need to go to the gym, right? Like that's not gonna work. So, right, yeah. You just need to eat more protein. Oh, okay, will do, no problem. So we need to let them feel better. And because we can't ask women that are at their wits' end to just go buy a gym membership. So we need to get them started on the medication that is going to give them their sleep back. And they can actually have a bit of energy and start feeling like humans again. And then you say, great, I am so glad you're feeling amazing. But now I need you to do some work. Now I need you to take the money that you would have paid for the bullshit supplements and buy a pair of running shoes. And I need you to go out for a walk after work every day. And when you're starting to feel better and get some energy, then I need you to go buy a set of weights or invest in a gym membership and start lifting heavy shit. So I think just the basic, like, we need to get you functional again. And once we get you functional and you have a bit of extra energy to do stuff, let's go for it.
When you say bullshit supplements, could you be more specific about what you consider to be bullshit supplements versus other supplements some of us might be taking? Would be
Yeah, so I mean,
vitamin-like.
right, so multivitamins, vitamin D, calcium, iron supplements, like that's great. It's more here's your fancy menopause one that has a list of 500 ingredients on it that is going to make you magically feel better. Is what I get concerned about.
There's menopause.
More kind of menopause specific ones. There's excellent studies that have looked at like black cohosh and soy and red clover, something or other, and yams. And when you do them head to head compared to a placebo pill, the placebo does better. So there's not great evidence that those things work. And again, you can spend a lot of money on them.
When you say calcium, do you think that most women should be taking calcium?
I don't think most of us get it enough from our diet.
So what if you're vegan, which is what I am?
Mm-hmm.
So
Mm-hmm.
I'm sort of like a flexi-vegan, let's
Yeah.
say.
Yeah.
So the only calcium that I eat is yogurt,
Mm-hmm.
Icelandic yogurt
Mm-hmm.
usually.
Mm-hmm.
A couple times a week. I
Yeah.
don't eat any
Yeah.
other dairy
Yeah.
source, but I eat tons of more kale than most people
Yes.
We can have
Yeah,
opinions, but we
yeah.
should still feed them.
I still think you probably would benefit from a calcium supplement because I don't think most of us are getting enough from diet.
Is that something you can test for, calcium levels, or no?
Not as well as you can test things like vitamin D, and you need the vitamin D to absorb the calcium as well. Pretty much all of us are vitamin D deficient because we live in Canada. You
I
know,
take lots of vitamin D.
yeah, great. And like we don't see the sun, and when we do see the sun, we slap the sunscreen on so we don't get skin cancer. So like all of us are vitamin D deficient. So yeah, having that vitamin D then again, so that you're absorbing that calcium well is fantastic.
Mostly you would say people should take calcium.
It's just our bone health is so important, and losing our estrogen rapidly loses our bone mineral density. So I think anything we can do to help with that.
And even if your bone density test has no indication, like if your bone, so I had a bone density test,
Mhm.
perfectly fine,
Beautiful.
still should take
Prevention.
calcium.
Prevention.
What about creatine?
I don't know enough about creatine. I've heard a lot of good things about it. I'm not a nutritionist, so I can't speak with much authority about creatine. I've heard a lot of good things, but I can't. It's not the bullshit supplements that I've heard about. Yes, this is being recorded. You can tell I have salty language, and I do that in my office too. I'm just going to say I don't know enough about it to feel like I can speak with any authority about it. Yeah. Nobody's asked about libido.
You didn't have it on the slide.
Sorry. I was going to see if it came up because this comes up every day in my office. And it's usually the, okay, well, we'll see you in 3 months. What about door on the handle question? Is it normal that I have no sex drive? Oh my God. Because it's super important. And it's a big discussion that's not usually a 30-second, okay. Incredibly common in women in perimenopause and menopause. And we are complicated beings as women. We can't take little blue pills and then be good to go because our sexuality lives up here. And our sexual response has so many parts to it. The first place I like to recommend people is I have 2 authors who I adore, Dr. Emily Nagoski and Dr. Lori Brotto, who have written extensively and have great books that teach us about how our sexual response system works. What are our accelerators? What are our brakes? Stress plays a huge role in it. It's also kind of normalizing what most of us feel. Like most women do not have spontaneous desire. Most women do not walk into a room and say, let's take our clothes off. We have reactive desire. We have responsive desire in the right situation, in the right timing, when the dishes are done and somebody else is looking after the kids and I feel good about my body and I'm relaxed and all of these things, then we can get there. But most of us don't have spontaneous desire, and that's what we think libido is. Most of us don't have orgasm through vaginal penetration. It's clitoral stimulation. Again, life is not like the movies. So one part is learning about how our brains work. Another part is making sure sex doesn't hurt. Because why in God do you want to do something that hurts? So we need to also make sure that is addressed, that things are feeling good. And then when you've kind of gone through all of that and being like, no, stress levels are good. I still like my partner. I think he's cute. We still want to do this. My vagina feels good. I don't have dryness. I don't have pain. Then we kind of start looking at more the testosterone question. That we know that part of what we're no longer making through menopause is testosterone. That's what our ovaries used to make, estrogen, progesterone, and testosterone. And it's very off-label because we don't have any products in Canada that are testosterone-based meant for women. So I've got some International Endocrinology Society guidelines that talk about how we safely off-label use the products for men, like something called androgel, because there is evidence for transdermal testosterone use for what we call hypoactive sexual desire disorder in perimenopausal and postmenopausal women. So I do have some women where that's where we end up going, and they do feel good with that. But I don't think that every single woman who says, by the way, I don't want to have sex while I go to grab the door to walk out the door, needs testosterone. We need to talk about everything. Because if the answer is, I actually want to divorce my husband, that's very different, right? Right, exactly. Yes, no problem. Maybe you actually need women now. Like, I don't know where life takes us. But yeah, libido is super complicated. And people feel really alone about it, and they feel a lot of shame. And there is definitely a fundamental shift that happens with all of our hormonal shifts. There's a shift that happens about how we feel about our bodies. Do we feel sexy anymore? Do we want to take our clothes off? There's a lot of changes happening in here. I feel a little sweaty, and I haven't slept in 2 years, and all that sort of stuff. So it's something that deserves to be done well. But I do think educating ourselves on how our bodies work is step one. It's very eye-opening. And there's some people who do it really well.
Add that slide.
I certainly can.
Before you send it to
I can.
Sarah.
I can.
Before she sends it to us.
Yeah, certainly can. Certainly can. Yeah.
If you have an IUD
Yes.
and you're still not sleeping, can you
Yes.
also take?
Yes. Sprinkle in some Prometro.
Anybody have any extras?
Yeah. Yeah, there you go. There you go. You know, again, the IUDs are beautiful for managing the bleeding. They're great for managing the bleeding, but they're not changing what your ovaries are doing, right? So you're still going to experience all of your menopausal changes, but your uterus is quiet, but all the rest of the stuff is still happening. So again, individualizing it, see what other symptoms there are. Is it just that prometrium you need, or maybe somebody actually now needs some estrogen on top of that? You can certainly add in.
3 hours and then I wake up at 5.
Yeah.
So I get like 3 hours.
Yeah, so I'd be happy to throw some progesterone on there. Yeah, it's a great idea. Yes.
While you're on the Mirena topic,
Yes.
I'm just curious, so what symptoms is it supposed to manage for perimenopause?
Bleeding.
Yes, so
Bleeding.
I have not had my period in years.
Woo!
But the problem is I have no other way to then track
Yes, totally.
anything
Absolutely.
else what's going on other than knowing that I have anxiety.
Yeah, totally. So it's a great question. I have a Mirena and I haven't bled in years. Where the hell am I in for menopause? It's a great question. When I have women who come to say, please test my hormone levels because I want to know where I am in menopause, usually my answer is no. Let's talk about what you're feeling, what your periods are doing, because hormone levels, especially in perimenopause, are like this multiple times a day. So usually a one-time reading doesn't actually tell me things. I'm more interested in talking to people. What are their symptoms? What are things going on? The exception to that whole textbook 1 year without a period is when you've done something to remove your period. Maybe you don't have a uterus anymore. Maybe you've had an ablation. Maybe you have a Mirena. So this is actually a situation where a combination of asking about symptoms and actually doing some blood work and looking at a level called FSH, which is the hormone that drives from the brain down to the ovaries, is helpful to try to figure out where somebody is. And also, often in the situation of, do I need the Mirena anymore? So if I have someone who's 55 and she used to have periods with her Mirena and they stopped 3 years ago, and she used to have hot flashes and night sweats, but now they're done. And I check her FSH and it's like 80. And I'm like, well, you're screamingly menopausal, but you're not having any other symptoms right now. You're feeling good, so we can probably pull that Mirena. So that's kind of where that is helpful. But if it's like I'm still within my lifespan of this Mirena, I'm not having any periods, but I'm starting to have menopausal symptoms, it's a bit of a judgment call for me whether they even need blood work to figure that out. I'd rather treat the symptoms, whatever those happen to be.
Because is there any research that Mirena actually cause or can make you more anxious?
That a Mirena can make you more anxious? Not really. And especially if not that it's been in for a long time and all of a sudden the mood changes are new. That's probably more, right, yes. Yeah. Rarely, I've had someone who finds on a Mirena that they do notice mood changes, and that if I take it out, their mood instantly gets better. But it's pretty uncommon, just because the Mirena does really sit locally at the level of the uterus, and the full body absorption is really small. But there are some people who are just exquisitely sensitive to hormones. So it's hard to start piecing out of like, are my mood changes because I'm perimenopausal? Is it a reaction to my Mirena? Is it because there's a shit ton going on in life right now? You know, it's can be really tough to piece through like, why is this mood change happening? Yeah.
I have one quick question.
Yes.
Is it pretty common to sort of hit a plateau like 6 months after you've started HRT, like and have all the symptoms return again?
Some people do. Some people
And
do.
is that just tweaking the
Yep,
dosage?
Totally. Yeah. Yeah, it's frustrating because you were great for how long?
Yes.
Totally, it's so frustrating. Yeah, so sometimes that is just a matter of tweaking the doses, and often that is maybe a reflection of what your baseline estrogen is doing. You know, maybe you were doing this, and now you're doing this, and so what you needed here is different than what you need here. So sometimes that does just require tweaking. Yeah, adjusting things, trying a different type. That's why we're really lucky that I have this whole cookbook full of different options that sometimes we do have to play to just find the right combination for somebody. Yeah. Yeah.
And just further to that question, so if sleep then, like if that was one of the things that was off,
Yeah.
could you just, if you were only on 100 milligrams of the microRNA
Yes.
progesterone, you could go to 200, like take a second.
Absolutely.
Pop the second one tonight.
So
There you
can
go.
I just do that
Yeah.
without having to go and make an appointment? Can I just start taking more? She nodded her head there. You've just given me the okay? Okay.
Not on the video,
I just
though.
prescribed it to you.
I was about to say, did I prescribe it to you? Or like, yeah, no, I often with Prometrium, I'll tell people like start at 100, see how you feel, give it a couple weeks, but then
And you don't have to
play.
adjust the estrogen.
No, exactly, because adding more progesterone is just more protection for your uterus. Like there's not a negative part of that. If you're increasing the estrogen, you have to match it with the progesterone. But if you're keeping the estrogen the same and you're just trying to see if you can get some better sleep or better things, then just playing around with trying 2 at night instead is reasonable. Yeah, I'm happy for women to, especially with the progesterone component with that Prometrium, to play around whether like 1 versus 200 milligrams is the right dose for them. Again, this is my personal practice, not speaking for everybody. But I think it's important to have that autonomy to play a little bit as long as we feel like it's safe. Yeah. Yes.
Just to piggyback on that, so you
Yes.
can take the progesterone without taking estrogen,
Yes.
but you wouldn't take estrogen without progesterone.
If you have a uterus, correct.
If you have a
Yes. Yeah. Because again, it's the estrogen is the fertilizer, progesterone is the lawnmower. If we give you nothing but fertilizer, we give you cancer. If we just give you a lawnmower, cool. Yeah, progesterone is there. It's all safe, but progesterone is really safe. Micronized progesterone is super, super safe. Yes.
You said at the beginning with estrogen compounds that it's not consistent.
Mm.
So is that like the gel that you would get from the pharmacy?
So if it's a brand name, so the brand name gels for estrogen are Estrogel and Divigel. So those ones are Health Canada approved. Like Estrogel is a metered pump. Every pump, you know exactly how much it is. Or the little sachets of the Divigel, you know exactly how much is that. I've just seen some like bi-est creams. Again, progesterone in cream form, my stomach drops every time I see that. And I'm like, please don't have cancer. Just because I know progesterone's not well absorbed. But yeah, yes, Estrogel, Divigel, those are the Health Canada approved transdermal gels. With the transdermal estrogen, I usually recommend thighs because there's a nice big surface area with lots of muscle and lots of fat, so great places for things to absorb.
And should you swap thighs or just stick with one?
Doesn't really matter. Doesn't really matter.
Yeah.
Yeah. This side is super estrogenized compared to this side. Yeah. Doesn't really matter. Yeah. Yeah.
So back to what Liz was saying about the IUD.
Rena, yeah.
if they, because I'm the same as her, I've kind of cared for years.
Love
So
it.
they- yeah, it's great. So they did the levels, and
Mhm.
mid to high.
Mhm.
I really don't need it, but I like it because I don't have night sweats or hot flashes.
Right.
So
And
they're
there's
taking it.
really no harm to keeping it in. And even when you hit that point, just from a safety standpoint, you kind of even want to give yourself another year, because heaven forbid you pull it and all of a sudden those periods come back. That's the worst. So, yeah, so the increase from using Mirena from 5 years versus 8 years is really specific to its contraceptive effectiveness. That we know from a birth control standpoint is going to prevent pregnancy for up to 8 years. From a use as part of menopausal hormone therapy standpoint, like when we're relying on our Mirena to balance out the estrogen, we still only have the data for 5 years. Right now, I'm hoping that'll change in future as we have more data. But if somebody is using it as part of their menopausal hormone therapy, we use it for 5 versus pushing it to the 8. But yeah, if you're not on estrogen and you're just loving life on your Mirena, keep on keeping on.
Do you have a preference between the gel and the patches for estrogen, the estradiol?
Personally, I have more experience with the gels. And especially, with the estrogel, again, people kind of have that autonomy of like, do I want to give myself 1.5 pumps? I can try 1 pump, I can try 2 pumps. So like when we're figuring out the doses, I feel like it gives women a bit more autonomy to play with what their happy place is with gels, as opposed to a patch where I have to prescribe a brand new patch at a different strength. So it's more back and forth to the pharmacy of like, now I want a 100 microgram patch versus a 75 microgram patch versus blah, blah, blah. So I find especially when I'm playing to find a dose that people like, I often like the gels better. There's some people who don't like the volume of gel that has to be put on their skin. So often that's where we go more the patch route, just because it's less physical stuff. If they're feeling like an oil slick with all the stuff coming off of their skin. Exactly. And people who travel a lot and don't want to have check a suitcase, and then they can't bring the estrogel bottle and blah blah blah. Like, right? So that's again why I have a whole cookbook of things work differently for different people depending on what they like, their lifestyle, all that stuff. This has been really fun.
Really good, thank you.
Thanks, ladies. I hope this was helpful.
You have something really exciting to share too about what you guys are you allowed to talk about what you're up to?
Oh, yeah. I mean, we personally are moving my office. So, yeah, right now we're in the Shipyards medical building. And I share practice with Dr. Susan O'Toole. And we're moving into a very cute little house. So across from CCI, kitty corner to the Tim Hortons, that adorable bright pink door is now going to be our new home. We're renovating it. And we've partnered with Collingwood Pelvic Health, which are some of our awesome pelvic floor physiotherapists in town, Jess Doig and Lisa Mitchell, that they're moving with us. So now we're going to have this space that they're going to be there full time and we're going to be there full time. Dr. Robin Stark, one of the other gynecologists in town, is going to come and do some of her work through there too. So we're just kind of making a fun little women's health place. Part of our dream is a rapid access sexual health clinic when we're across the street from one high school and down the street from the other high school. Come and get your IUDs and your implants and your condoms and your preventing teen pregnancy. Yay! Contraception is the other thing I'm very excited about. We're kind of hoping that we can kind of get that going, take advantage of our high schools very close, and people can just swing by the Pink Door House and get what they need. That's what we're doing. Just exciting.
Thank
Cool.
you very much.
Yeah.
Appreciate having you. Thanks everyone for coming. Thank you.